So, welcome to this session on navigating the challenge of health and aging in the global south. We will be exploring the perspectives and pathways to resilient aging. My name is Anthony Ngugi. I come from the Aga Khan University in East Africa. And just want to say right at the start that we will be hosting the regional meeting for the World Health Summit for Africa in April next year, and we hope to see you all there. So welcome, and I'm very honored to be chairing this session. So maybe a very brief overview of why we are gathering here to discuss this very, very important topic that is largely underappreciated, is that we're actually gathering at a time when people everywhere are living much, much longer than ever before. Just to give you a number, by mid this century, a third of the global population will be over the age of 50. And this is definitely success in longevity, but then it does raise really important questions regarding, for instance, how will health systems, how will families, and how will communities adapt, especially in places where resources are limited. In many developing countries, we see that aging is transforming societies in really significant ways. Just to give you a few more numbers, uh, just 5 years from now, that is 2030, uh, about 80% of the population aged 60 and above will be living somewhere in a low and middle income countries. Think about that. In sub-Saharan Africa, where we come from, the population that is age 60 rose over 50% just in the last 15 years to the current estimate of about 65, 67 million people. And even more interesting is that there are projections that look at doubling, tripling this number in 25 short years, that's by 2050. There's no nation that has ever faced such a rapid population aging anywhere in the world. When you look at the examples from more developed countries, it actually took many decades, up to century, to double their population of 60 and above. But where we live, in the context of sub-Saharan Africa, some countries like Kenya and Uganda are actually looking at tripling or quadrupling this population in just 3 to 4 decades from now. So we don't have the luxury of time to prepare. And what these figures are underlining is actually not only the scale of the challenge, but the speed with which we really must address this issue. So population aging is definitely a triumph of health. But the downside or the other side of the coin is that it does strain systems that are unprepared. And then our health services are ill equipped to handle chronic diseases of old age. There are no geriatric services, for instance. We are not able to deal with conditions like dementia. Many times, elderly in rural areas, even in more urban areas, do not have a healthcare provider that they can go to. In many instances, they must make a choice between either buying a meal or skipping treatment. Then there's issues of formal long-term care. These are nascent wherever they actually exist, if at all. And then the families who are the default caregivers of the old people are actually really stretched. It seems that in this setting, everything is lacking. What about outside the health system? Socioeconomic gaps also further imperil this promise of healthy aging. For instance, pensions, safety nets are really minimal, and this is why many seniors are left to be dependent on charity or relatives. And in many places, these old people are living either in poverty or in pain or in both. Even basic needs such as clean water are actually out of access. And these realities do highlight urgent gaps and need for financing infrastructure, as well as appreciating all the social determinants of aging and poor aging outcomes are that we must address really urgently. But not all is not lost. there's hope. Today, from a global perspective, we actually see that older adults drive up to spending in up to a third of the global GDP. There's innovations across the world, including the global south, where there's pilot of solutions from telemedicine, community health clinics, age tech applications that can support aging. Then there's the issue of Africans still yet strong family networks. There's evolving public health programs. And then there's the large youth population. And these actually do provide rich ground for experiments that can enable creative and inclusive aging model. So in this session, we want to discuss evidence, ideas for resilient, equitable aging across societies. We'll explore a range of topics from policy reforms, financing strategies, community programs, innovations, long-term care, amongst others. And all this can ensure that old people everywhere can live with dignity, they can live with good health. So I want to thank you all for attending this session. And this being here is actually an indication of your curiosity and the commitment to this issue that is a truly underappreciated global mega trend. I'm sure that together taking this forward, we can turn the challenge of aging into a catalyst for healthy, inclusive progress. So to help us address this very important topic, I have a panel of very distinguished experts in this area. And I think I will not be able to do adequate justice trying to describe their bio sketches and CVs in the short time that we have. So I refer you to our web page for the session. But just a very quick introduction. I want to start from my extreme right. We have Dr. Awin Tan, who is a Senior Director of Health Thought Leadership at AARP, that is formerly the African American Association of Retired Persons, but just simply ARP now. He directs efforts on health longevity, addressing health disparities, and challenging ageism. Please welcome him with a round of applause. Then I have my colleague, Dr. Muthoni Gishu, who is from my home country of Kenya. She heads the Division of Healthy Aging, Palliative Care, and Older Persons in the Ministry of Health in Kenya, and also serves on the board of Alzheimer's Dementia Organization in Kenya. Then coming to this table here, I have Dr. Alexandra Karache, who is from Brazil. He is a global expert on aging, and he currently serves as the president of the International Longevity Center in Brazil that he co-founded many years ago. And then to my left here, I have Professor Jean Cook Lee. She's a research professor of economics at the University of South California, where she directs a program on global aging, health, and policy. So I want to dive right into our discussion, and I want to start with the issue of policy and financing of aging programs. Yeah? I want to start with Muthoni. We decided we'll start with the youngest. So with the LMICs experiencing this rapid demographic transition, which we actually agree we need to change that name into population aging for more traction, we see that it will triple the older adult population within a generation, as I described previously. And then what we are seeing is that policy responses remain fragmented and reactive to a large extent. So in your opinion, what reforms do we need to prioritize to promote healthy aging? And is there a place for international community and global partnerships to better support governments to develop and implement sustainable aging policies?
Thank you very much, Anthony. And that is a very interesting question for a couple of reasons. Developing policy is important, and getting to be able to implement that policy is even more important. So when you ask, are there policies that we urgently need. To start with, we need to mainstream aging into all policies, because it is important that we're able to shift the thought of aging from a peripheral perspective that is looking at older people only when they get older, to looking at it from a central point of view, having a life course approach. I like saying that nobody wakes up one day and they're 60. Maybe in the future when we can do cloning, when I can clone myself at 60. But for the meantime, it is a journey. So having the life course approach means that we mainstream aging across all sectors. It is not a health only business, because again, they say where you live, where you're born, your environment affects very many other things about and around you. So we need to see that we can have that in many sectors. Further to that, we need to have legislative action that protects older people. We can have an act, but not be able to actually enact it. Is it helpful for our people? Maybe, maybe not. Then in the context of Kenya, for example, we will talk about pensions, like you rightly said, and social protection. In my country, 80% of the population is in informal employment. So what does that mean? It means that pension or a pension scheme is out of reach. And then we want to talk about social protection. One of the things that we have that has worked very well, we have Inua Jamii cash transfer for older person, but it only caters for a certain group of older people who are 70 and above. And there has to be a couple of things that need to be assessed for you to get onto that program. Is it possible for us to get to that point where we can actually have this age group of people that we agree on that have a certain way of socially protecting them and also adding to a means of income and possibly, actually most critically, giving them dignity? Because you can imagine what somebody feels like when they have to decide, are they going to buy their medication or are they going to buy food? And do they need to dress? Maybe, perhaps. Also being able to integrate systems in healthcare. We have lots of silos everywhere. How is it that we can integrate aging and geriatric services into primary healthcare, into community healthcare? So looking and also building a responsive workforce. Like you rightly said, currently our healthcare system is reactive and probably not ready for chronic or managing chronic conditions that are quite common in the older people. So, and then you ask, is there a room for global partnership? But of course, it's the reason why we are here, I would suppose. And we need to, it is actually layered. There is a bit on technical assistance that is not prescriptive. So when you're talking about the partners that support these programs, whether it would be the World Health Organization, UNFPA, or any other organization, how do we contextualize the technical support that we offer or use or that we offer to support the development of policies and contextualize it to the different context of LMICs? And then thinking about having a platform where we can have the global South to South learning. And one of the things that I'd like to look at is, for example, the UN Decade of Healthy Aging learning platform. How much of information or how much resources do we have from the global South on that platform? How can we enrich that platform so that we can learn from each other? And then there are very many things that we could actually do, but we have to bring it down to a community level. And we need to be able to fund our spaces so that we can pilot and not only leave it at a pilot place, but also scale up to a national level and to also see how best we can use our available resources to manage what it is that we need to scale up. And one other thing that we really need to think about, and having attended one of the sessions about global health financing, we actually need to see how to best work on our local resource mobilization, because that is most probably the most sustainable option.
Thank you very much. I just pick on the thread of financing and learning across contexts, and I want to direct this to Jean Cook. Yeah, definitely, as Muthoni says, we see that as populations age, the demand for healthcare obviously rises sharply, especially for chronic diseases, long-term care, palliative services. But definitely the issue of resources is a major challenge. So how can health financing systems in these settings adapt to growing cost of aging populations, while at the same time they actually need to ensure equity and distribution of these resources across all the different age groups? Are there any successful financing or policy models that can offer valuable lessons for adaptation in these settings?
Thank you, Anthony. And I do think it is a very important issue to think about the financing of healthcare systems. And there has been a lot of this sort of dialogue. I've been an aging researcher for a long time. About a decade ago, when population aging became a real issue in East Asia, like China and Korea, a lot of people started paying attention and worrying about how can we finance this, because it's so costly. And especially with the emergence of NCDs, the healthcare system currently is so much focused on the treatment, which becomes very expensive. And there, the solution is paying more attention to early diagnosis and detection. So the systems in those kind of countries, instead of following the more treatment-oriented healthcare systems, countries like Korea and China turned around, develop national healthcare systems, doing the detection of hypertension and diabetes at age 40. So a lot of things get treated much early on, making healthy aging possible, but also having that cost model, really having a control over that. So I think it's just having our mindset toward prevention and early detection will have a huge financial incentive for the government systems, and that's something that Global South can also adopt. So I do a lot of research in Global South, and especially my country that I put a lot of energy on is India. And India has a healthcare system with both public sector and private sector. And many of the elderly, especially those who are under poverty, is having an access to public health care is very critical. In that country, there has been a lot of successful examples, especially in the rural area. When they set up healthcare systems in rural area, actually elderly in the rural area have a better health outcomes than elderly in the urban area, because the government initiative has not been implemented in the urban sector. So we can again demonstrate the importance of policy actions, providing a preventative care or the care at the before disease become too severe. So I think that would be a very important option. And in terms of thinking about financing all of this, I mean, as an economist, I believe in the incentives. And even yesterday, there has been a lot of a dialogue about the effectively using the tax systems, such as tobacco tax, right, alcohol tax. Those tax system provides the funding to the government that can then turn around and can be used for the providing support for the health for the elderly. So I think that will really provide both solutions for having a healthy population as well as creating a resources to make those kind of public health campaign possible.
Still staying with you, given your vast experience in
Anthony,
running.
could you speak closer to the microphone?
Oh, okay, yeah. Sorry. Still staying with Jean Cook, given your very vast experience in running large population aging studies in developing countries, advising many other studies, the place of research and addressing evidence gaps, yeah, as evidence on aging and its health and socioeconomic dimensions remains quite limited, fragmented, and for most part is actually quite inconsistent. So what are some of these very critical research and data gaps that limit our understanding of aging and health? And in what ways are they impacting policy making and program design in these settings?
So I do believe the importance of data, and a lot of policymakers, they want to, in theory, develop evidence-based policy. But if there is no evidence, how can they develop evidence-based policy? That's just not possible. So collecting data is very important, but in a lot of in LMIC countries, we don't have the infrastructure to develop high quality data yet. So I think it really takes the initiatives to develop that, take that initiative to build the databases. And I know there has been successful examples like countries like Kenya and Egypt. People are making an investment in building the data resources. There are a few important elements that we need to be mindful about it when we develop those resources for policymaking or developing a scientific evidence base. The first of all, when we develop a database, we need to make sure that we recruit the right sample, because at the end of the day, policymaking is targeting for larger population base, not just a small group of very sick elderly or a group of very healthy elderly. So creating a sampling strategy that will be really making inferences for larger population base is really critical. The other aspect of developing high quality database is thinking hard about today's elderly and how can we capture their not only health status, but the surroundings they are living in. Because we do all know that how our health is influenced by socioeconomic circumstances. It really comes under the skin. So having interdisciplinary data that captures not only health outcomes, but also various social, cultural environment, as well as other aspects of environment, especially the physical environment, as well as chemical environment would be very important. There has been a lot of challenges in even capturing the healthcare, and especially if in the environment where access to healthcare is not very well widely open, how can you know if you just ask older others, do you have diabetes? Do you have a hypertension? They cannot answer you. They don't know what diabetes is. They don't know what hypertension is. To being able to measure their health, utilizing the right, not only the survey type of instrument, but also through the blood test, through other ways to capture people's health outcome is very important. There has been a lot of advances in technology, in mobile sensors that will allow us to capture people's health without relying on healthcare systems. So I think those are important aspects of it to develop when we create the databases. And I think one very important lesson is we cannot just borrow the model that was developed in high-income countries, because that worked in the high-income settings. When we start applying or adopting these building on infrastructure, there are, of course, a lot of good lessons to learn. But when we apply that into global south, I think there is a lot of attention has been paid to how to best capture it. It's a problem-solving process. There are a lot of good reference points, but that's not the solution. So being able to look at what's in local context and being able to adopt how to collect the high-quality data in that setting would be the very important key innovation. And that really comes into the science comes to that. It is an opportunity to really innovate and capture both health and environment in global south, much more innovative way that really not only develop a better understanding, but also push the science so we can develop a better knowledge on understanding the population health and aging. Thank you.
Thank you so much, Jean Cook. Definitely building robust research ecosystems in these settings does require both global collaboration as well as local leadership, as exemplified by some of the examples that Jean Cook has talked about. Now turning to you, Awin, this confluence of very rapid population aging and this really dire scarcity of evidence means that we really need to prioritize some areas of research. Yeah? So what priorities do you think we need to have in terms of capturing or collecting data that would allow us to make immediate investment to improve health aging?
I mean, data is going to be key to creating the futures that we want. One of my favorite quotes is by the science fiction writer William Gibson. The future is here. It's just not equally distributed, right? And what we see in many developed countries is a much more older population. And so what we are going to be seeing over the next few years is that increasingly people across the globe will have the opportunity to grow older. And that's actually something I feel that we should celebrate. There's a phrase at ARP that 50 is the new 50, meaning that your personal age, is the first 50. The second age, 50, is what society feels that age represents, right? And most countries are far away from having median age of 50, although Singapore will probably be there in the next 10 years. But across the globe, I think we need to see this, demographic transition of global aging as a success story that people across the world are now being able to grow older. So how do we support that? I think the ability to have data that can allow us to track health metrics is going to be important, because that's how we can identify where the resources need to be best allocated. And I think the key here is that who owns the data? Like, if data is to be accessible, people need to trust to give that data. And it's not only data on health status, it's also data on minority groups. For example, in the United States, we talked about equitable distribution of aging. There's a recent article in the Lancet by IHME, talks about 10 Americas, right? So if we look at the data in the United States, look at Native American residents of the Midwest and Western part of the United States, life expectancy at birth in 2024 was 62, which is comparable to Cote d'Ivoire or the Democratic Republic of Congo, right? For Black residents of the Southeast US in rural areas, life expectancy is 67, which is comparable to Ethiopia or Pakistan, right? But knowing that data then allows us to ask why, and allows us to ask how we can fix it, what has caused these disparities. And the next piece is that how did we get here across the world? The populations are aging in part because, well, we were successful in saving people when they were infants, children, and improvements in maternal mortality, right? We saved the young, and that's amazing. But from a demographic perspective, you can actually only do that once, right? Now the young have become middle-aged and increasingly older, right? So I think the next piece is trying to improve people's health span. It's not lifespan anymore, it's health span. And in some ways, many of the diseases that we see in developed countries that are associated with lifestyle, these are increasingly problems that are going to be globalized as well. And so getting data on the population health and understanding also that in terms of equity, that understanding how women are doing is also key, because in terms of the data, the future of aging, the future of the world is not only aging, it's also increasingly women, because women generally tend to live longer than men across all populations. So this is an introduction, and we can have further conversations about data.
Thank you, Erwin. I want to switch gears a little to the area of health systems and infrastructure. And I want to start with you, Modoni, before I come to you, Alex. So the legacy of infectious disease focused model has left our health systems, especially primary care, very ill-equipped to deal with these chronic long-term conditions. So maybe you can make a comment on the preparedness of the systems to this phenomenon of population aging. What are the key gaps? What are the key weaknesses in health infrastructure that pose the greatest challenges to providing quality care for older adults?
It's interesting that we get back to this again. So earlier we talked about the healthcare system being reactive, and that means it is prepared for acute conditions. But then again, when we cross to the other side where we have to deal with chronic conditions, multimorbidity, and the longer lives, clearly we are not very well prepared for that. And then when we look at the gaps that we have, I could start with the workforce. Like looking at one, how many people do we have who are trained to be able to offer care, and especially for older people? For example, in Kenya, we probably have 1 or 2 geriatricians, and this is to serve a population of 3 million people, because we have about 3 million people above the age of 60. And like I said, this is using a health cost approach, then it means that we need to build more capacity for that. And this is across board. We do not have training for nurses, clinical officer, community health volunteers, or community health promoters. And what does that mean? That we are at the point where we have demand for services, but we cannot supply or take care or manage that. And then looking at the other bit of infrastructure, for example, how friendly or are our systems age-friendly? Possibly not. And then when we look at our medicine and supply chain, we know that as people grow older, there are certain medications that are more important and are needed more for them. And we're talking about non-communicable diseases. I know it's been a conversation in this forum a couple of times actually since day one. And how easy is it to access the medication? And then again, we go back to the bit about social protection and dignity. Will this person afford the medications that they need once the diagnosis is done? And then looking at the long-term care and the palliative care, are these services that are accessible? And chances are very high that this end-of-life care or palliative care is limited. If we look at the other side of it, what opportunities do we have? We actually have a very well-running community health promoters space, which can allow us, or which will allow us to create demand, to create awareness. And these are a population or a workforce that would actually bring in a lot of change. Why? Because we will be able to do screening at a community level. And then having to see that our primary healthcare service is age-friendly. So we're not saying all is lost. The thing is, we have a lot of work to do, yes. And yes, we can address those gaps, but then it needs a lot of collaboration and political goodwill.
Thank you so much, Muthoni. Alex, there's evidence to show that countries that have started to successfully improve elder care demonstrate the value of integration, training, and innovation. I think Muthoni and other colleagues have mentioned that a bit, but I just want to hear from you. Are there any promising or even proven approaches that can help strengthen healthcare infrastructure for aging? And if there is, what are some of the key investments or policy changes that we need most urgently to scale this?
Thank you, Anthony. I would like to take the opportunity here first to contextualize a little bit. And this is coming from someone that recognizes that the most important achievement of the last 100 years is aging. It has taken 15 years for the World Health Summit, and I'm very close to the organizers, to have a room that is the smallest one, and it is half empty. We still have a long way to go, and this is called bringing enthusiasm for embracing aging as it is. In 1900, the highest life expectancy in the world was in this country, in Germany, and was not even 45. I was not programmed to be here when I was born in Brazil in 1945, so you can do the counts. It's going to be 8 years next Friday. I was not programmed to be here. Most of my peers have long disappeared. And yet we are still struggling to bring attention to aging for many reasons. And the most important one I will address at the end of this introduction. I have worked in many different capacities, 20 years in the academia in the UK, mostly at the University of London and Oxford. Then I moved to WHO, and I was the director of the Aging and Health Program, with a very small budget, continues to be very small, in spite of the decade on healthy aging, which I don't think should be on healthy aging, because we should be addressing the social determinants of aging. That is more important than to be talking about biomedical issues related to old age. The social determinants. And we learned this from Ilona Kikbush, the leader of the World Health Summit. Health is created within the context of everyday's life, where you live, where you work, how you get around the city or where you are around, what you eat, what you can afford to eat. And not to blame the victim. Hey, mister, could you please eat more broccolis? But if I eat more broccolis at the beginning of the month, I won't have any flour or sugar at the last week of the month. Then I moved to WHO for 13 years. It was a struggle. A small budget. And I want to bring a life course perspective. We are not talking about old age, we're talking about aging. The best thing that can happen to you, young, is to age. Just think of the alternative. So let us stop talking about old age, like so many people do, which is, what a burden, what a problem. Would you prefer to die early? And then I moved on. And I want to acknowledge the presence of Joe Ivy Buffer, the president of the New York Academy of Medicine. When I left WHO, I joined Joe at the New York Academy of Medicine to implement what I had left as a legacy in WHO, which was the age-friendly cities global movement. Today present in thousands of cities. But we thought, Joe and I, that if New York would be an age-friendly, it would have an influence throughout the world. And yes, we do have. How many here are from the global south? Could you raise your hands? This is more or less half of the group. But it is where action is going to take place demographically, as it has already been indicated by this demographic transition. It's not in the north. I'm not that concerned about what is going to happen in the United States, Canada, or Europe. Although you are not providing a good example, health expectancy is declining. Inequity is driving force. We know that inequity is bad for health, especially for aging. And not only it is declining, but also health life expectancy is on decline. So we are adding more bad years to life when we should be adding more life to years. It's a major challenge. And unless we move on, and let's say in 3 or 5 years, we will be in the plenary of the summit, not in this shy away, small room, half empty. That's not addressing what I consider to be one of the most important challenges for the 21st century, which is aging in the global south. The glass is half empty or half full. Because next week in my country, in Brazil, we will have a longevity forum in São Paulo. And there are already 6,000 people registered. What I'm saying is that we can do it if we do the research, if we do advocacy, if we bring the media, if we talk non-stop. And this is my legacy. My legacy is to bring aging into the agenda, has always been. When I looked 50 years ago, when I first arrived in London to do my postgraduate there, I said aging. And I continue to be determined. At the time, nobody would stop to talk to me, let alone to listen. But I have converted some people. I can see Ingrid Keller right at the back there today at the European Commission. She was my intern, and she was a champion, working solidly, convinced that aging is the best option. Now, there is a reason for all this. And unless we tackle this reason, we are going to be failing younger people today, older people tomorrow. And this challenge is called ageism. The term was coined by Bob Butler, who established the first International Longevity Center. He was a friend, he was a mentor. And this was in 1969. And 50 years later, we still don't listen to Angela Davis, the champion, the activist in the United States in relation to racism. It's not enough not to be racist. You have to be anti-racist. I paraphrase this saying, it's not enough not to be ageist. You have to be anti-ageist. You have to fight and raise your finger. We have just launched a small guide on anti-ageism. It's in Portuguese, but I hope to translate it in English. And next week, I'm launching a book, which is not a technical book, because those I have written in the past. What is important is to reflect about my life working on this. Legacy is not what you leave behind. And I work on gerontology. I know that I don't have many years ahead. In a few years, I will go. Legacy is what you construct, what you build as you go on. Not thinking about, are people going to talk about me? I am not interested about this. I want really for younger people to take these messages and not even attribute to anybody. But the question you ask is the most important one. It's the culture of care. We need to develop the culture of care. It has gender perspectives that are incredibly important. Men, wherever, with few exceptions, they conjugate the verb to care, like he cares, she cares, you care. I have nothing to do with this. I want to be cared for. It's not going to work. It's not going to work because in my country, we are going to jump from 34 million older people today to 68 in 2050. And 2050 is tomorrow. It's enough for you to be 35, to be 60 and over in 25 years from now. And it is the life course perspective, paying attention to social determinants. And this culture of care is essential because you are wasting resources. We don't have clear policies in most of the global south, and I dare to say also in the north, because I have worked in so many different countries in the developed world. And I think that we are failing because we don't want to contemplate what is the most certain thing that can happen to us, to die. And because we're afraid of dying, we don't want to address that. I want this room full of people enthusiastic about aging. If not as enthusiastic as I have been for 50 years, at least half as much. And I want to meet you again in the larger room.
Thank you. Thank you, Alex, for that very comprehensive overview and response. Just want to assure you that your efforts are not in vain. There's a lot of young people, Dr. Modoni, myself, and so many others included, who are actually now taking this forward and really addressing it seriously from various dimensions. policy research, and all the others. So I want to come back to you, Jean Cook. Definitely, there's a range of social determinants of aging outcomes that, as
It
Modoni
was
mentioned
half
earlier.
empty. Now it's going to be 1/3. Bye.
It's okay, we continue. Yeah. 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 So we need to find ways of integrating these social determinants into national aging policies, not just from the health side, but socio-economic and all others. But definitely this does require coordination across various sectors, that is health, housing, infrastructure, and the others. Just wanted to hear from you whether there are any practical strategies or cross-sector collaborations that can effectively address these social determinants to reduce isolation of older people, ageism, as Alex so eloquently described. If they are, how can we ensure that such approaches are systematically integrated into health and aging policies?
Thank you, Anthony. It's very hard to follow you, Alex.
It's a tough act, yeah.
But I do
I
think
can grab enthusiasm.
it's very hard. I mean, I'm a dry economist working in academics all my life, thinking hard about the data. And when we try to compare different countries or age outcomes, health outcomes, having a same indicator is very important. Otherwise, we cannot compare apples with oranges. In order to make meaningful comparisons, we try hard to develop a data system that will allow us to make comparisons between countries, not only between the countries, even within the countries, different generations, because aging is a process and every birth cohort goes through different aging process. And being able to use the same parameters to follow people and make comparison is important. We all talk about social determinants of health. Alex talked about social determinants of health. And there has been a lot of researches on various social determinants of health. And based upon the evidence, what turns out to be the strongest determinant has been on education. And we know in many of the global souths, there is mandatory education is not there. Free school is not there. So I think to me, that is the first policy action that we have to take, providing education to our young children. And aging is a process, and it starts as soon as we are born or in our mother's womb. And providing them with an education will have a lifelong impact. And there has been many effort to looking at effect of education on various health outcomes, starting from the cardiovascular outcomes to dementia outcomes. And we have found that in high-income countries, increasing education has an effect of preventing dementia of over 40%. When we did a study in India, we found that effect is even greater, approaching to 70% reduction in dementia prevalence. So you can see the impact of those education having an influence on health outcomes. It not only has an impact on prevalence measures, but it also reducing the gap, especially the gender differences. When you go to different, especially in global south, you see big difference between men and women. And when we start reducing the gender gap, and when we look at whether it's mortality or dementia prevalence or cardiovascular outcomes, once you control for education, you no longer see the sex differences in health outcomes. So you can see the power of education that helps not only making us live healthier life, but also living in an equitable, healthy life. So I think we would need to collect those information to make such a comparison. And health is directly linked to social well-being, the personal well-being. There has been various indicators of well-being that we've been also collecting. So we can not only talk about the functional abilities, but also being able to talk about the satisfaction with life and the meaningful life that ageism would have a harmful effect. In order to make that statement correctly, we actually need indicators that build such a structure.
Thank you so much. Jinko. I want to come back to you, Alex, and we just give an opportunity to continue with the thread on care. And this time, to continue the thread on care, this time I want to focus on long-term care. Yeah, I think it could represent one of the greatest barriers to successful aging in developing countries. And given the changing family dynamics, family structures, whereas initially or traditionally families used to provide care for the elderly, and this is now changing very rapidly. I want to hear from you. Do you think there's space for long-term care, for instance, long-term care facilities? And what are some of the challenges that are there to establishing this sort of care? Then that is one. Then for community as well as family care providers who actually undergo a lot of challenges due to limited resources and competing priorities, how can we better support them to provide this care?
The issue of long-term care is absolutely critical. It's critical because in most countries, we expect that the family will provide care. Which family? What are we talking about? Are we referring to families when I was a child, when my grandmother had 17 children, my great-grandmother, and then that generation had 8, and then 4, and then 2, and then 1 or 0. I have a niece who doesn't have any child, and she's about to get into menopause. She's not going to have children. She adopted a cat and castrated the cat, so there was no replacement. And that is the challenge that we have, that families are growing vertically, not horizontally. When I was a child, there would be an army of women who had not joined the workforce, and they would be available to provide care, to few older people. And because there was very little to do in terms of medical technology, they wouldn't last long. So it was easy to provide long-term care. No longer. But we still have that family structure that no longer exists as if it is prevailing. Throughout the global south, we are going to see major changes, and one is driven by urbanization. That is why we launched age-friendly cities and communities, aware at the beginning of the century that the driving demographic forces of this century would be aging and urbanization. More and more people are going to age in cities. Are they prepared? No, they are not prepared. And therefore, we launched in WHO the age-friendly cities, and I refer to age-friendly New York as an example. Fantastic. But I also knew, as Joe knows so well, that at New York Academy of Medicine, which is in the far end north of Central Park, facing Central Park, from my office, I could choose to open the window and look to the left, and I would end up in the Golden Mile with an upper east, with a life expectancy at the time around 90, the highest in the States. But I could also look to my right, and equidistant, same about 2 miles away, life expectancy would be 15, 20 years lower in Harlem, the Hispanic Harlem. These inequalities are absolutely critical for us to think about long-term care. Long-term care in my country has a major achievement. We are the largest country with a national health system, universal. Model in the British system is a bit in crisis, in disarray, but the national health system in Brazil is thriving. So it's fantastic. It's a sea world of change from when I was a medical student, that people would have to queue outside the public hospital, get a number, and they would be lucky of waiting for 10, 12 hours to be called by a doctor. At midday, somebody from inside the hospital would come and say, sorry, the doctor has finished his or her shift. More often, his. A bracket here. I have hope because in my country, today, the majority of medical students are female. When I was a medical student, only 8% were. I think that this feminization of health professions will also bring more, I hope, humanity. You women are much more likely to be compassionate than we male, testosterone-driven are. So there are changes that are occurring in terms of long-term care. And I'm proud to say that under the current government, not the previous one, definitely not in the states under this present government there, we are seeing a change in long-term care. And in spite of all the opposition, 3 months ago, we have endorsed, the Congress has endorsed a new law on long-term care. A country that is developing, like Brazil, that has the largest national health system, where health is a right, it's not a favor that somebody is giving to you. And now with the long-term care law that will divide the duties of caring between the family and the state, not the government, the state. So it is a law. And I hope that this will be a civilizatory, it's going to change the way we perceive. And my last word on this, I'm proud that we have today a WHO global network on age-friendly cities and communities, about 1,750 cities of all sizes. But there are many more thousands that are not even enrolled. In the United States, driven by AARP, we have over 350 cities and communities, and in Canada, about 980. I'm not interested anymore on cities and communities. You all know probably the word, and I'm not proud of acknowledging that is probably the only contribution from Brazilian Portuguese to the lexicon, to the dictionaries, favela. You know what a favela is. I want to make age-friendly favelas in Kenya, in Brazil, in Latin America, in Asia, in the United States, because the slum areas are not a privilege of a country like Brazil. They are everywhere. They are here in the outskirts of Berlin or the outskirts of Paris. And the little that we can do in a favela has much more impact on public health than lots that we can do for affluent neighborhoods that don't need that project in order to thrive.
Thank you so much, Alex, again for talking about what you started off in Brazil, sustainable models of care. As we move towards the close of the panel, then we can go to the audience for questions or comments. I just want to now shift gears a little bit to the side of innovation and its transformative potential. And I want to direct this to Awin. It definitely goes without saying that innovation can truly become an indispensable driver for healthy aging. I just want to hear from you, what are some of the roles that these innovations can play? What are some of the innovations that are there? And what are some of the roles that they can play in ensuring quality of life for older adults in Global South?
I think that, what Alex said about that it's not enough to add life to years to life. It's adding healthy years to life is more important. One of the interesting developments is this idea of geroscience, which believes that we can affect the biological rate at which we age. One of the major nonprofits in this field is XPRIZE, which provides, it's a competition, right? So X Prize has a health span competition, not lifespan, but health span. And the idea is that if you can reduce, if you can reverse someone's health span by 5 years, improve it by 5 years, X Prize is holding a competition that will give you $101 million in 2030. It's being primarily funded by the Saudi foundation Hevolution, right? And this idea that that focusing on people's health is important because as people age, the tremendous economic benefits of increasing the amount of years that you can work as long as you need to or want to are critical. So if you look at low and middle income countries, 85% of the growth of people 65 and older will occur between now and 2050 in middle and low income countries, 85% of the growth of the older population. At the same time, the idea of seeing an aging population as an engine of economic growth is also important. In 2020, ARP did a global global longevity economy report. And it looked at countries, 76 countries, 95% of the world's population. And it showed that people 50 and older represented about 34% of the total GDP of the world, about $45 trillion, right? And so if we can invest in people and allow them to work as long as they need to or want to, that then generates more and more economic growth. So I think the idea, this perception of aging as primarily that of a negative event is one of the things that we have to fix. From a personal perspective, if you have a positive perception of your own aging, Becca Levy at Yale has found that you have, on average, 7 years more of life expectancy. If you have a positive perception of your own aging and you have a ApoE variant, ApoE is a protein in the body. If you have an ApoE2 protein, which is protective against cognitive decline, a positive perception of aging enhances that protective effect. If you have an ApoE4 variant, which puts you at higher risk for increased risks of Alzheimer's disease, positive perception of aging will help reduce that risk. And from a national perspective, I think to take advantage of this aging population requires us to combat ageism, requires us to reimagine the social structures within society, to think about aging as a lifelong process. In ARP, we talk about our mission as to empower people to live as they age, because aging is about living, right? When I was at Hopkins, we did a study looking at volunteerism and the health benefits of volunteering when you're older. There's a program in America called AmeriCorps. It's the sort of domestic version of Peace Corps, which many people are much more familiar with. And in this randomized controlled trial, we placed older people who are 55 and older in the Baltimore City public school system. The Baltimore is a urban, often poor, a city with a lot of urban poor problems, right? And what we found was that the women who were in the randomized section, who were engaged in volunteering, were more physically active. Why? If you go to a kindergarten room, there are these rapidly moving objects that cross your path called kindergartners, right? And you have to pause, you have to like shift your weight, sort of like Tai Chi, right? You have to sit a little lower because the chairs aren't often built for adults, often built for children. But what's fascinating is there was 10% of the cohort were men. And talking about developing a culture of caring, what we found among the men is that the men in the intervention versus the control had sustained hippocampal volume compared to the control group. And why did we find this enhanced benefits, cognitive brain health benefits for the men? Was we felt that this may have been a generation that previously had not encountered childcare, right? And one of the things we know about brain health is that novel experiences are good for your brain. And anyone who's ever tried to teach a kindergartner or third grader how to read, it's a challenging experience. You're looking at them, they're looking at you, and somewhere between, you have to find an understanding about what's on the page. And so that, I think, is an important piece, that we need to embrace aging as an opportunity, both from ourselves, our personal life course history, and from a societal perspective, and reimagine programs like Peace Corps, AmeriCorps, volunteer programs, work programs, as opportunities not only for investing in youth, but continuing to invest in society. And for the children in those schools, there was decreased disciplinary action. So it's imagining the older adults as a resource, and that in terms of lifelong education, the importance of education, both for the children, the next generation of people who will be older, and the older volunteers who are maintaining their cognitive activity in trying to teach. Those are the examples of trying to create these intergenerational programs that help continue to increase those bonds of affection between the generations, and also have a huge economic benefit for the community and also the nation. So those are some other ideas I think we should think about.
Thank you so much, Irene. I mean, very interesting. Do you think what you just mentioned, intergenerational sort of approach to improving quality of life, cognitive performance of older adults, are these, in your opinion, programs that would be scalable to low resource settings in Global South?
I think that every society is going to be different. But I do think that every society is different. I think what you need to think about are the issue of trust. Find institutions within each community where people trust each other, right? And schools are one place, religious organizations, community centers, and then think about how we are segregated by age. Increasingly in the industrialized world, people live in the same age cohorts, and then try to reimagine those institutions, volunteer work institutions that then allow people of different generations to live together. I think those are some of the considerations as well.
Thank you so much. I want now to turn over the microphone to our audience. Please circulate a microphone. Try to make your questions short, crisp, and if possible, can mention who you're directing your question to. So I want to take the first three, and then we can have those responded to, and then we can come back to you.
Right.
So 1, 2, the gentleman here, 3, and then 4. Then we can go to the next round.
Thank you. Good morning, everyone. My name is Dr. Adana Steinaka. I work in women's health for the Nigerian government. Thank you for a very enlightening panel session. My question is about elderly care, especially in the Global South. So for many countries and many parts of the Global South, elderly care is really considered a responsibility of the family. I saw that with my grandparents and my great-grandparents. But as society is changing and as younger people are going more into the workforce, and as traditionally care being a woman's job, with the fight for equality and women going back to work, it's not sustainable. That form of care is no longer sustainable, where your elderly parents or grandparents move into your house. And yet the talk about other forms of care, like elderly homes, is still considered a taboo. I've tried to have this conversation in small settings, and it's still considered a Western thing, and it's considered a failure on the part of the family. So my question is, how do we start to shift that mindset about what care is going to look like 10, 15, 20 years from now? And how do you think the perception of the new forms of care is going to be welcomed, especially in the Global South? Thank you.
Thank you. Please keep your question short. I think you can start there or there.
Good morning, and thank you for very richful and insightful conversation. Alex, I see you live with a purpose and work with passion, and you transmit that passion to all of us. So thank you for that first. And when talking about navigating challenges on aging, 2 out of 3 people above 60 uses at least one key enabler: assistive technology. Eyeglasses, hearing aids, walker, wheelchairs, and yet still forgotten. Because when we talk about the Global South, many of these products are not manufactured for local settings. So my question is, knowing that these are key enablers for aging, for functioning, for communication, for mobility, for self-care. How are you navigating, and how, from the perspective of the economic investment, from the perspective of service delivery for long-term care, how is it being included?
Could you identify yourself?
Sorry, I should have started with that. Dr. Karen Reyes, I work at AT Scale, the Global Partnership for Assistive Technology. Thank you.
So let's have this gentleman here, and there was somebody, the gentleman at the back. Then we'll take that round of questions, and then we'll come back to the audience. Yeah.
Yeah, thank you, Chair. My name is Peter. I am a doctor. I come from Uganda. And Alex, you've told us a length of activities. On this date, you'll be doing this, and that. That's exciting. I love the enthusiasm. What plan do you have for countries like Uganda for capacity building, for trainings, so that they are grounded in the concept of aging, so that you can get a pile of foxes and set them on fire, and they will run this voice for aging, and we shall celebrate the aging, as we have said. What plans do you have for us so that we can get better, so that we know exactly what needs to be done? In terms of data, you've talked about lots of things about data, you've talked of research, you've talked of all these other great things. How do we get there in terms of the ability of the persons providing the care? Thank you.
Thank you so much, Peter. And finally, this gentleman for the first round.
Yeah, thank you guys so much for the informative session. So I'm Bob Shin, and I'm a year 1 medical student from Hong Kong. So this session is very informative in how we approach aging. I'm wondering, because there's so many lifestyle factors that can help us combat aging, is it possible so that we condition the youth into these lifestyles, perhaps through some policies, in order to condition themselves better for the future? And also, besides this question, I also have some flyers from my friend at World Federation of Public Health Association, because a lot of us here are interested in the global south. And actually, next year in September, my friends are hosting this World Congress on Public Health in South Africa. So you guys are welcome to take some flyers and maybe just see how it's perhaps interesting. Yeah, because as Dr. Tan said, novel experiences can really help your brain, right? So this is one of the novel experiences you can engage in. Thank you so much.
Thank you so much. I think we'll take it. There's one question specifically directed to Alex from a gentleman in Uganda, that is on capacity building at local level for this type of work, specifically Uganda and similar countries. Then there's a question on changing mindsets about long-term care. I think, I don't know who wants to take that. Okay, fine.
Yeah, would be better.
Sure. Then there's one on assistive technology, and what kind of awareness can we create at a younger age so that you can ameliorate some of the
Let us
effects.
address the
So,
questions as
yeah.
we go.
Go ahead first, Alex.
Because they are intertwined. These
Okay, fine,
questions,
yeah.
they have so many points in common. I'm going to first start with you, the medical student from Hong Kong. Could you stand up? How old are you?
I just turned 18 last month.
Sorry?
I just turned 18. Yeah, last month.
Okay. Suppose that you have a medical student who will qualify at the age of 25. That is when I qualified in 1970, 55 years ago. Suppose that you are 25 and you qualify in 2025, and you work for as many years as I have as a medical doctor. I had already been working. You add 55 to 25, and you end up in 2080 in a completely different world. In a world that is going to be much, much, much older, and yet you are not being trained. In Brazil, only 10% of medical schools have geriatric medicine in the curriculum as an obligatory discipline. If it's not obligatory, the medical student is not going to follow. You're not going to be evaluated on that, why bother? And everything changes with age. Don't expect that you will look like you are now in 2080. Anatomy, physiology, physiopathology, pharmacology, the interactions of medicine, presentations of the diseases, but you have not learned. I'm not that interested in training more geriatric physicians because I know it is difficult. We have a deficit in Brazil of 28,000 geriatricians. We should have about 30,000. We have 2,000 accredited by the Brazilian Society of Geriatrics. What I want is that every single health professional, not only doctors, nurses, physiotherapists, nutritionists, and so on, learn more about aging, because you're not going to deal with children forever. Residents in Brazil, by definition, they are young doctors, increasingly young female doctors. Well, 11% choose obstetrics, but what the hell are you doing in obstetrics? You don't have children anymore. 11% in pediatrics and 0.4 in geriatric medicine. So we have to turn this. And the obligation is for the leadership in the academia. The people that are teaching, that are responsible. We need an educational revolution to follow the longevity revolution. And as it happens, Ingrid Keller, who is right at the end there, Ingrid, could you stand up? I'm going to bring this. Ingrid was, if not the best, I think the best intern that I had at WHO. And it was Ingrid who helped me to have a joint project with the International Federation of Associations of Medical Students, to have a project, this is in the early 2000s, which was Teach Me Geriatric Medicine. Do you remember, Ingrid? It was a lot of work to convince, to have you young people as ambassadors, because you are the future older people, but also you are going to grow to your career dealing, like it or not, with older people. And it is impossible for you to like and be enthusiastic if you don't know. You can only like what we learn. That is related to Uganda. It's related to Nigeria. Nigeria is going to have a population later this century of 800 million. You're going to be the third largest country in terms of population. There will be a huge demand of people leaving Nigeria, trying to escape poverty, unless you make a huge effort to overcome underdevelopment. And in particular, those that are well trained. We have seen this. We are seeing this every day. People desperate crossing the Mediterranean to reach European countries. So development is essential. But the reality for Nigeria is that family structure is starting to change, and you have the elite getting the best, like in my country. And unless you have a national health system that will provide basic care with community health workers like we have trained in Brazil, provide basics. Don't expect to be too sophisticated because you don't have the resources. And if you do that, you will have an impact on the field. I hate the expression silver economy because it gives the impression that we're creating this beautiful silver, golden economy. No, I want the basics for most and not the best for the elite. And it's going to be tough, believe me. And the last point is related to what you have said. Throughout the world, and it's very common in my country anyway, when you introduce yourself, you describe yourself for a matter of inclusion. There may be deaf people or blind people, and you describe yourself. When I describe myself, I say, I'm old, I'm bald, I need glasses, I have white beard, I have wrinkles, and I'm proud to be old. Because if we continue to say, me, old, no, old is somebody else. If it's not introjected in you, you're not going to address aging because you don't regard yourself as old. And again, reminding, you're not young forever.
Thank you. Anybody wants to contribute to some of the other questions? Assistive technology, long-term care, socialization of society.
Yeah, I would like to talk about the technology part. And where we are at, we keep looking at next innovation, the next high-tech technology. How about if we looked at that from a slightly different perspective and look at what is that we can do with the low tech that would reach out to more people? And it's about the new models, the new processes, and how creative we can get with what it is that is available. And again, trying to contextualize what it is that we have to our different contexts. I will leave that one at that. And then the care models and how it is that we might talk about a change in mindset, but also how creative do we get? And one of the things that is doing very well in the global south, and let me talk about the African continent, is social media. So if we can strike a balance on edutainment, where we get to educate and entertain at the same time, and we're able to create awareness and change mindsets or give information that will help in making decisions for different kinds of people. So I think that is a tool that we already have that we can actually utilize to inform.
I also wanted to add in the issue of adaptive care and what you had previously said about bypassing certain technologies. In the United States, for example, traditionally hearing aids have been something that you had to get a prescription for. And within the past 5 years, there's now a new brand of over-the-counter hearing aids that you can purchase that can be adapted from things like smartphones with iPods, for example, being substituted to serve as hearing aids or over-the-counter hearing devices. So there is the ability to bypass certain technologies. About 6 years ago, ARP sponsored a National Academy of Science, Engineering, and Medicine workshop on perceptions of aging and disability and their impact on health. And we actually hosted it at the Parsons School of Design, School of Fashion, right? So it was a fun day. One of the things that we talked about there was the new technology of 3D printing, right? And they were using 3D printing, for example, to create shoes that were individualized for people with foot deformities. I think that there's also the ability to think about how we can use the newer technologies like 3D printing to then create adaptive equipment at the local site and potentially even cater to the individual, which I think is even more exciting because as we age, we actually become much more diverse in terms of our needs, our abilities, and our aspirations.
Thank you so much. You can have the last round. Very short questions. We have about 5 minutes remaining. We have 4 hands. So please circulate the mic. Please try to keep it short so we give everybody a chance, then have the responses.
Thank you, everyone. My name is Karsten. I come from Kosovo, and we run a private-led health system, ecosystem. And in Kosovo, we have the problem that we are the youngest country in Europe with the average age of 30, but we are aging very quickly. And Last 6 years, population decreased by 15%, and we have no solutions. And with our college, which is one of the elements of the ecosystem, we collaborate with Germany, and we realized that what we need to learn, we don't learn from Germany. And we are rather culturally like the global south. The question is, what are countries we could learn from, or institutions or initiatives we could reflect with?
Thank you. So the next person, please.
My name is Martina Merten. I'm working at the Charité Institute of International Health, and I'm really pleased to be in this panel because just like you, I've been attending the summit since 2009, partly organizing, partly reporting, and now finally this aging topic is here and is represented. So a big thanks to the organizers. I've been pushing this topic forward for the longest time, started with NCDs in low and middle income countries, got interested in aging populations on the Asian continent, conducted research in India, and finally, 3 years ago, went to Karnataka, which is a southwestern state in India, and conducted qualitative research in public free of charge homes, trying to analyze how females age 60 plus are coping with moving into institutionalized care. And everything which you have just talked about here was partly represented in this research. It was a changing culture of the formerly joint family system into a more individualized system. All of these women which I interviewed had family, but none of the family was actually taking care of them. So they suddenly found themselves exposed to this institutionalized care and trying to cope up with the experiences. And these were really heartbreaking insights, but at the same time also inspiring, because all of them were actually coping up well, because they embraced the new environment, and through daily activities, they learned how to live a new life. And many of them became very old, age 80 and older. So this is just to reconfirm what you have said. There are new models, and also if awareness or new forms of care are there, this is a new way. Of course, family is still the best way to grow old, but there are also additional forms of aging, and this is just what I wanted to share. So thanks once again.
Follow with the panelists after this. So the next question, please, and then we can, I think there was one more.
Okay.
Please go ahead.
So thank you so much. Excuse my ignorance if it would be there, but we have spoken about your, my senior doctor there has told us about it's about aging. It's about aging and not old age. So my question is to Dr. Mudhoni. Africa is about 70% of Africa is the youth, right? And at some point we will age. So what are the steps there that that you can talk about, that you can take, that will take advantage of having the advocacy from the youth to talk about aging and to create the conversations going and help us prepare for the old, getting old and aging as well. Yeah.
Thank you. There was the final one. I don't know who it was there. Maybe just the lady here in red, last one. And you can have very quick reactions to the feedback, comments.
Thank you very much. I'm also from Kenya with this team. I'm a member of parliament looking for legislation.
Oh.
Is it really something to legislate on? And I want to experience. First, I want to thank the presenters. This is wonderful. I think it's an area that has been ignored for a very long time. I was in the 10th parliament in Kenya when we decided that we must have this social fund that we give 2,000 shillings. But the trick has been, even in that 20 years, the little fund that you give to the elderly is being used by the younger ones in the family. Either you are paying fees directly for somebody who is in need, and everybody is waiting for that money that belongs to the over 70 as part of the family. That I don't know how it's being handled elsewhere and whether it's a challenge in other places, that the family hierarchy of needs seem to be stealing the money from the elderly, whom we thought they were going to age gracefully, enjoying some meat once in a while and enjoying health. The second comment was on the issue. I was waiting for a full answer, which I didn't get, because culture is very dominant in the South. Culture is something else. I don't know, and I don't know whether our team from Aga Khan University have done this research, acceptability of homes. Because if they were in homes and receiving their 2,000 in homes, it would be spent on them. But so long as they're in the family, it is very tricky for us. And we have been asking ourselves, even as members of parliament. Currently, I chair Health Committee in the Pan-African Parliament. That's what brought me here. And I keep asking myself, do we legislate again to make it to make things different so that this money can be spent on the elderly? How will you do that if the oldest in the family is still considered the breadwinner by everybody else around them? Yeah. Experience from elsewhere. In Brazil, do you have homes for the elderly, or where you are elderly? And where are you taking them? Where are you taking care of them? Thank you.
Thank you. Thank you. So very quick reactions. I think we've finished with our time, but two very quick reactions from the panel, and then we can have ongoing discussions after this, because we have to release the room.
Let me quickly address exactly that point. Even in the United States, when the check was given to the household, that money was not used for the elderly, that money used for the grandchildren or the other members of the household. So back in about a decade ago, the payment system have changed. What US did was created a bank account of the elderly member's name, and the money is sent to elderly person directly. So nobody can take out the money but the elderly. And that really changed the United States, the older adults. One last point I'd like to quickly make is going back to the hearing aid and vision issues that raised earlier, because those are very important issues. And sensory health, attention to sensory health has been escalated a lot recently in academics, but also there has been a lot of partnership has been developed with the hearing aid companies, with eyeglass, eye hospitals. So I think there is a great future to make a stride on the research and also the implementation in that area. Thank you.
Thank you very much. There's a lot to talk about, and definitely we have to close, but I encourage you to engage with the panelists as they go out for lunch. Just have a quick chat, exchange contacts. But definitely we have our work cut out to address this very, very glaring challenge of rapid population aging. Yeah? So let's continue this conversation in our spaces, and let's convene in Nairobi, where we'll also, hopefully, Alex, have a plenary for the same. We'll actually be launching a nationwide aging study in Kenya at that time as well. So thank you very much. Enjoy your lunch.